Thank you, Mathieu and Joanna. Dear ladies and gentlemen, yes, what's new in 2022 and personalized therapy already in clinical practice? What I'm trying to do is to show some things that are most likely going to happen in the future and show some things that we are all doing or should be doing. So let's get started, my disclosures. And I'd like to divide this in 3 parts. And I think there are three sections where we can actually include personalized therapy in IBD already today. And the first is prediction. Maybe that's more the vision. Then the second one, where we actually personalize therapy. And the last part will be adapt, where we adapt ongoing therapy. So let's start with the prediction part. And probably the majority in the room knows what I'm going to show here. And those are the data generated by James Lee, and actually at this time in Cambridge, started over a decade ago, where he could show that if you take a profile of CD8 positive T cells, and when you first diagnose IBD and then follow up the patients, you can create a profile that can distinguish between a high-risk cohort and a low-risk cohort. And so this concept was further developed and resulted in a study shown here on the left-hand side, and with a panel developed from this original study. And here you can clearly see the low-risk and the high-risk cohort, and illustrated up here. And also illustrated down here, so the high-risk cohort needs much earlier TNF blockers than the low-risk cohort. And this has been a validation study, and now the big clinical trial, which really stratifies patients according to this test, is ongoing, the so-called profile study. And I hope that we are going to have the data next year, and then I think we all will know whether this is a strategy to go. And I think it will help a lot if we see the patients the first time and know this is going to be a complicated disease course, or whether we know, oh, it's rather going to be easy, and I don't need to bring in all forces in the very beginning. Okay, so this is prediction, and prediction is future at the moment. So now let's get to personalized medicine. Of course, we all wish the test where we see the patient for the first time, we take blood, ideally, and do some fancy tests, and then the test tells us, oh, this patient you start with vedolizumab, this patient you start with anti-TNF, this patient you start with a JAK inhibitor, and so on. Unfortunately, this is not available. I'm not sure when we are going to get this test. However, there are markers out there who are pretty good in predicting at least some response to therapy. And I'm going to show one example. I'd like to start with one example here in the following. And this is oncostatin M, and a member of the IL-6 family. And this work here was done by Fiona Powry's group, by Nathan West and Ahmed Higazi, couple of years back, and what they could show is that in inflamed tissue in ulcerative colitis and Crohn's disease, you see an upregulation of OSM and OSM receptor. And if this is highly upregulated, and this is shown on the right-hand side, you see that those patients are refractory to anti-TNF treatment. So, is this a specific marker for anti-TNF if it's highly upregulated? Is this a specific marker for anti-TNF refractory patients? The data were confirmed by the Leuven group, and they could equally show here, if this is upregulated, you get no endoscopic remission, and you get for the OSM and the OSM receptor. Remarkably, they included a second cohort, a vedolizumab-treated cohort, and again, if OSM was upregulated, it was less likely that the patients would respond to vedolizumab, and the same for the OSM receptor. So, my conclusion, I might be wrong here, but my conclusion from this would be that the upregulation of OSM and the OSM receptor is rather reflecting the course of disease rather than telling us specifically whether or not the patient is responsive to one or the other anti-cytokine strategy. So we might need to spend a little bit of time on evolution of disease, evolution of the cytokine profiles during disease, before we really come up with good marker panels. So this is, again, this is a little bit future. What is not future is this. And this is a very nice study done by the UK group, published 2 years ago, basically following 1,200 patients with Crohn's disease being treated with either infliximab or adalimumab in the presence or absence of an of an immunomodulator. And the cohort was observed, and longitudinally, they were measuring anti-drug antibodies. And by this, they could identify a specific HLA locus, DQA105, which could be associated with the development of anti-drug antibodies. So now you know which patient is more likely to develop antibodies. And I think this itself is very helpful. And the next slide here is showing which patients actually survive without anti-drug antibodies. And the red lines are all indicating patients who carry the risk HLA type. And you can see that irrespective of whether or not you have the risk HLA type, combination therapy favors the non-development of anti-drug antibodies. And if you put the patient on monotherapy in the presence or absence of the risk locus, you have a higher probability of developing anti-drug antibodies. So yes, you can determine the HLA type, but it's quite expensive. But you can also say the patient is at risk, so I just start him on a combination therapy, and then I decide later on what I'm going to do with the combination therapy. And I'm coming back to this situation at the end of my talk. So I think this is really something where we can personalize the therapy. The next thing is, and this might sound a little bit stupid, but I think it's simple, and it might actually affect the course of the disease the patient is taking. And this is that we can always do fancy things, but we can also start simple, and we can just perform a tight monitoring of our patients. And what we should do is we should define goals, treatment goals in the very beginning, and those consistent. Shown here is the figure of the STRIDE-2 paper, indicating that we have short-term goals on one hand, indicating that the patient should show a clinical response, this is obvious, but also decrease in biomarkers, CRP, calprotectin. And on the long-term view, we aim for mucosal healing and maybe even for transmural healing and histologic healing. I think this is discussable. Does this make sense? Does this really lead to something that is better than that what we are currently doing? And I think the CALM study has shown us that this probably makes sense. And what the CALM study basically did, so Crohn's disease patients were first treated with prednisone, and then they were randomized to, they all got adalimumab, and then adalimumab was adapted according to either just clinical activity and prednisone use, or clinical activity, prednisone loss, calprotectin, and CRP. And the primary endpoint was proportion of patients with mucosal healing and no deep ulcers in week 48. So it's a very, very simple approach, right? And I think this is something everybody here in the room could do immediately. And what we see is it's not like that one group is 100% and the other group is 10%, but we see 46% versus 30%, and I think that's already quite a difference, considering the small, the minimal thing that has been done. So just looking at calprotectin and CRP in addition. So what I'm trying to say here is we should schedule the follow-ups. We should make sure that we include objective parameters in adapting therapy, in evaluating disease activity. And this is, for me, this very much reflects to personalizing medicine. Yeah. The last point I want to make for this second section is something we very often don't talk about, right? So we are gastroenterologists, and we are happy if we succeed in controlling intestinal inflammation. So, but sometimes it's worth asking a couple of questions outside the gut, right? So if you look in the eye of our patients and the eye is red, there's obviously something wrong, so that's easy. But we should ask, whether under the pullover or under the pants there are skin lesions which we just don't see, or whether they actually have arthralgia in the morning and morning stiffness, which we should consider. And this can immensely affect treatment decisions in our patients, because as shown here, we all know that there are drugs that are better, which is anti-TNF seems to be, and JAK inhibitor seems to be like the joker for extraintestinal manifestations, but there are others that do not affect extraintestinal manifestations. And I'd just like to point out, for instance, that anti-IL-12, anti-IL-23 is an excellent drug, but it's very bad if the patient has in parallel axial spondyloarthropathy. And the same kind, if you have severe psoriasis, which is difficult to control, then you can team up with the dermatologist and can immediately start with an anti-IL-23 or anti-IL-12, anti-IL-23 antibody. So I think this is something where we all can personalize treatment of our patients immediately and start this in our clinical practice. So the last couple of slides, I'd like to talk about ADAPT. And this is also something which we very often avoid, right? The patient comes in our outpatient clinic and tells us, and we ask him, how are you doing? And they say, well, I'm fine. I can do everything. I can travel. I can work. Family is fine. No worries. We're very happy. We just write the new prescription. Maybe we take some blood and make a new appointment. But maybe we should consider whether or not we can actually de-escalate therapy. So going back to the second part of to the beginning of the second part of the talk, where I suggested to start TNF blockers maybe more often in a combination therapy. So now we have the patient, for example, on combination therapy, infliximab plus an immunomodulator, and he or she has been running fine for quite some time. So when do we stop this? And what do we stop? Do we stop thiopurine, or do we stop the TNF blocker? And I think to answer these questions, because I think this is very important to think about this, I'd like to show the data from the SPARE trial from Edouard Louis. And what Edouard did is he enrolled patients, Crohn's disease patients, who were on combination therapy with infliximab and an anti-metabolite for more than 8 months and sustained in steroid-free remission for more than 6 months. And the aim was to assess relapse rates and time spent in remissions over 2 years after withdrawal of either infliximab or the thiopurine, and a third group was left on combination therapy. So the two co-primary endpoints were the relapse rate and mean survival time spent in remission over 2 years. I fear this is difficult to read. So in the first group, arm A, the combination therapy was continued, and if the patient developed a flare, infliximab was intensified. In arm B, infliximab was discontinued, and if those patients flared, infliximab was reintroduced and could then be further intensified if needed. And in arm C, the antimetabolite was discontinued. So in the first case, if those patients developed a flare, infliximab was intensified, and only if this didn't work, the antimetabolite was added again. So, and this is the result, which is very, very clear. So only if you stop infliximab, and this is the green line, if you stop infliximab, you really have a significant proportion of patients that develops a relapse over the 2-time period. However, the combination therapy and the infliximab monotherapy group, they really remain in a quite stable remission, suggesting that in patients that are on stable combination therapy, that have been in stable remission, that here you can stop the antimetabolite treatment. Probably what wasn't included in this trial was endoscopy, and probably today we probably would do an endoscopy to include this in our decision making. But I think the data nevertheless are very clear, shown here by the SPARE trial. With this, I'd like to summarize the personalized therapy in 2022. So we will soon know more about better ways of prediction. We will get the data of the profile study, and I think they will help us to predict disease course on a more molecular level. But currently, I think the best way to personalize is to really re-evaluate our patients regularly, define treatment aims, tell the patient, communicate your treatment aims with the patient so that both are in the same boat in your treatment strategy, and consider comorbidities and extra-intestinal manifestations when you make decisions which drug you choose for treatment. And once you've achieved your goal and you have a stable remission, you can wait some time, but at some point you need to think about whether or not there is the possibility to even de-escalate therapy. With this, I'd like to close. I'm happy to take any questions. Thank you.
Thank you. Please come to the microphone or send questions on the Q&A. Of course, we have plenty of questions with Joanna, so we can make it. But okay, for example, you say we need to de-escalate. I'm not sure. We have to discuss it with the patient in real life. It's important, and in the shared decision making is important. But there are situations where we should not de-escalate. Huh? You agree with that?
No, Mathieu, thank you for this question. I think I absolutely agree. But I think the combination therapy is something where we really should think about de-escalation. If a patient is on vedolizumab and has been stable, has no side effects, had severe disease before, I wouldn't de-escalate. But I think we should discuss this with the patient, because if we don't discuss, what happens is that patients at some point will think, oh, I'm stable, I don't have disease, I just stop. And I think then things are getting dangerous, because this is uncontrolled stopping, and this we don't want. Axel.
We have a question? Yes?
Yeah, Axel Dickners, Frankfurt, Germany. Britta, wonderful presentation. I like the third part, to adapt, yes. And you gave some suggestions, but should we not even go further? So you mentioned extraintestinal manifestations. We are now getting more the clinical endpoints like urgency, deferral time, and all these type of things. So will it become even more complex in the future when we have more granular endpoints? So we have now data on histology, for instance, for UC, and even more complex with all the drugs we have available?
No, it will become more complex, and I think I'm with you. I'm still hoping that we get this wonderful test who tells us what to take for which patient. But I think for the moment we need to start including endpoints that we define together with our patients to the time points. After 3 months, I want to be there. After 6 months, I want to be there. And this can certainly, if the patient tells me that the major thing that is burdensome is urgency, then I would include urgency in my endpoint. Yes.
Britta, we have a question on the same topic. Do you use histologic remission to de-escalate?
So, I mean, this is no. A very, very straight answer, no. But I'm happy to explain this. So what we regularly do when we de-escalate, that we scope, and I want to see mucosal healing. I'm not sure histology is always helping. But I'm really happy if I don't see any endoscopic inflammation, and then I would feel confident enough to de-escalate.
If we go on this concept of de-escalation, this is very interesting data from SPARE on anti-TNF, infliximab, and anti-metabolites. But this will probably not apply to all biologics because there will be different kind of and then I'm thinking about long effects for some of them, for example, or no risk of immunogenicity and so on. So how do you see, this is the future, you think, to have this kind of cycling?
I'm not sure. I think that maybe together with the profile data, and when we know that a patient in general is at lower risk, and he or she is on whatever treatment, ustekinumab, vedolizumab, JAK inhibitor, why don't we stop? Mm-hmm. I think the point is just if we stop, if they have endoscopic healing, and the patient says, well, I feel fine. I'm happy to stop. I don't have, I mean, if they say I'm finishing my PhD in the next year, then I'm getting married, I think this is a very bad time point to stop therapy, right? But if everything is stable, why don't you stop? But I think the key part then is to schedule follow-ups in a 3 months distance to really catch up if a new flare is coming.
I have a question as well, going back to the biomarker or biomarkers that we so much want, but haven't yet found. So how much, I mean, I know this is it's a difficult question, but how much would a biomarker need to add in efficacy to a specific drug, to justify, for example, its cost or its cost effectiveness? Oh,
no, but I think if we have a biomarker that would tell us that the likelihood is high, I'm not even saying very high, I would feel confident in trying it. My problem is with the data we currently have, and having seen the vedolizumab data, and we actually have, together with Ahmed Hegazi, very similar data than the Leuven group for OSM, that I rather think that all this is also a matter of disease evolution, and that we don't understand very well disease evolution from a molecular point of view at this point. And I think we should spend some...
And as a final comment, you mentioned HLA-DQ-A105, which has been replicated in another cohort, IBD, across different diseases and with different biologics. So this is very strong data, but we do not use it in practice so far. Do you use it?
No, we are not using it.
Who is using it?
We are not using it. Too expensive.
So it's dark, so we don't see, but very few hands.
Yeah. But I think even if you don't do it, if you're aware of this and know that if you at least start with combination, then decrease over, and then if you see everything is fine, you rely on the spare data and de-escalate.
So while waiting for biomarkers, we should use monitoring and treat to target. Yeah. So I think this was also a very nice message. Thank you very much, Britta. Thank you all.